Welcome to the University of Michigan Dentistry Podcast Series, promoting oral health care worldwide.
So one of the things we want to do is talk about classification of partial dentures. For ease of talking about partials among people, many times it's helpful with many of these things to help classify them. So if we go for a definition, again, this is in your notes. So it's in your handout anyway, but if we basically look at it's a prosthesis, okay, restores one or more, but not all of the natural teeth. If it restored all of the natural teeth, it would no longer be a partial denture, it would be a complete denture. Yeah? So one of the things that people don't always think about is partial dentures may either be fixed or removable. So one of the things that we talk about, more appropriately termed a fixed partial denture, is what many people commonly refer to as a bridge. So what you'd be thinking of is a 3-unit bridge or a 4-unit bridge. The more technical term would be a 3-unit fixed partial denture or a 4-unit fixed partial denture. And then on the other hand, we have removable partial dentures, which is more the topic of this course. And so for removable partial dentures, same things, replaces teeth or mouth structures of some or at least one, but not all of the teeth, and comes in and out. Comes in and out. So in the book that you've got, your Kroll manual, they do a pretty good job in the front part of that manual about talking about the different classifications of partial dentures. And so you've got the most common partials we do are class 1 or class 2 partials. And sometimes people confuse class 1 or class 2 because the class 1 is the more common. That's bilateral distal extension. Class 2 is unilateral distal extension. And so sometimes people think Class 1, they think one side, and Class 2, they think two sides. And so the Class 1 is bilateral distal extension. Okay, Class 2, unilateral distal extension. Class 3 can be either unilateral or bilateral. Okay, but the partial is bounded by teeth on all sides, so it's what we call a totally tooth-supported partial denture. So you're not counting on soft tissue to be the primary support in any area of a Class 3 partial denture. Class 4 partial denture, typically single edentulous area that's at and crosses the midline. It's front teeth. So when we say a Class 4 partial, we're talking about a partial that replaces front teeth with no other empty spaces. Okay? So O.C. Applegate, that used to be the head of a department here, developed lots of different things. What he had was some modifications for the classification. So if you're going to classify a partial denture, doing it after the mouth preps are done. Now what we mean by mouth preparations many times is not necessarily doing crowns on teeth, although it may be, and it's not necessarily grinding occlusal rests in teeth, but many times as we talk about the disease control / preparatory phase, there may be some teeth from the time you initially saw the patient, but before you're actually going to do the partial, it was decided that you're going to extract some teeth. So you wait to classify what kind of a partial you're going to do until all the teeth that you know are going to come out are out. So what you're looking to do your partial classifications are on the teeth that are going to remain in conjunction with the partial. Sometimes you'll have edentulous areas in the posterior. Let's say on either or both sides you have a first molar in a patient. And if there's no plan whatsoever to put a second molar on that side for the patient, you don't count that as part of your partial denture classification. So typically if there's a side where there's a second molar that's not going to be replaced, you don't count that. Third molars don't count. And additional modification spaces, added edentulous areas, are talked about as either A or P, as an anterior extra edentulous space or a posterior extra edentulous space. Class 1 or 2 situations take precedence over Class 4 situations and a Class 3. So what basically Oliver Applegate was talking about was if there are any posterior edentulous spaces, that's the primary classification of the partial. If there happen to be a bunch of teeth missing in front, that would be an anterior modification of whatever the posterior edentulous space would dictate. And that's gone over in your books, and I don't want to dwell on that inordinately. So if we say here's a Kennedy classification, because when you look in your Kroll manual, they talk about Kennedy classifications and Applegate classifications. They're essentially interchangeable. So the Kennedy or Applegate class 1 is a bilateral distal extension. So what you've got here is an example of both a maxillary and a mandibular class 1 edentulous situation. So if you look at your mandibular arch, okay, what do we have here? It looks like basically second bicuspid through second bicuspid. And then bilateral distal extension. And this little diagram in the center demonstrates the anterior teeth would be present and the teeth in red pencil would illustrate the teeth that would be replaced on the partial denture. And on the other side of the screen, it just shows you a maxillary edentulous case. Again, class 1, in which we have bilateral distal extension. So that's your class 1. A class 2 unilateral distal extension. Now here again, you might say, gee, here's a unilateral distal extension, but we're missing a second molar over on the patient's left side. Again, if we have no intention whatsoever of replacing a tooth on this side. So the primary direct retainer is going to be this molar right here with an occlusal rest, a clasping arm, and a lingual reciprocal arm, and then our only edentulous area that's going to be treated is going to be this single side back here. So though there's a single tooth missing on the patient's left, this is still called a class 2 partial because it is a unilateral edentulous area, which is what we're going to treat. And here's a situation that we have teeth all the way back, but here's a class 2 lower partial denture in place. So class 2 is unilateral posterior edentulous space. What if we have modifications? Okay, if you look at the one over here, okay, we've got a posterior edentulous space that would be a class 1, and then we've got this modification space bounded by teeth over here. Okay, so it's a class 2P. And here's one over here, basically, where you've got a class 2A, because there's an anterior modification on it. So the posterior classification trumps the modification spaces. Okay? And so basically here you've got a class 2 partial denture in this case with both an anterior and a posterior modification space. Or the one drawn here just in the diagram, here's your posterior edentulous space, here's your class 2, okay, with an anterior and 2 posterior modifications. So a class 2A, 2P. And it's just a shorthand way of describing these partials. So you've got the class 3. The class 3 is completely supported by teeth all the way around. So here you've got an edentulous space here, but you've got a tooth in back to support things and in front. So it'd be something like this. So that's a unilateral class 3. You can also have a bilateral class 3 partial denture. Here's the one in the mouth. It shows you basically the edentulous space here. Here's the partial denture in place, replacing these teeth. So that's basically a unilateral class 3 partial denture. Same thing bilateral. So here you've got 2 long edentulous spans, but it's bounded by teeth all the way around. And you can have these either in the mandible or in the maxilla. You can see there's a torus midline up here, so they made a modification in the major connector going across here to avoid the torus. But again, if it's tooth supported everywhere, it's a class 3 partial denture. The class 4 has no other edentulous spaces except the anterior, typically which crosses the midline. And so here's your classic Kennedy or Applegate class 4 partial. Now many times on these you can see the silhouette of the partial denture in the mouth. As you may imagine, a lot of times depending on how many of these anterior teeth are missing, class 4 partials can be difficult to get great stability on because when the patient goes to bite into a double beef Whopper with cheese on this, and all that's trying to hold this thing in is the clasping on the posterior teeth, can you envision that these types of partials tend to tilt forward a little bit a lot of times? It's really difficult to stabilize them completely. And so these are situations in which if a person had the ability in these anterior areas to place 1 or 2 strategically placed implants, leave them at the gum line, and you could use those zest locator attachments just like you use on your mandibular 2 implant supported overdentures. If you basically had a zest locator implant in those areas, it aids these types of cases tremendously. So it's not that you're necessarily trying to make it an all fixed appliance, But even if it's still a removable appliance, a strategically placed implant can go a long way toward giving you incredible stability on these things. Can really help out a lot. We don't really do these anymore. They used to have these things called unilateral or Nesbitt bridges that were these little single teeth replacements. And once in a great while we have patients come in wearing these, or they've had one and it's broken a clasp and they say, can you make us another one? We don't make these things anymore for patients. Anybody got any idea why? What are we afraid of? Swallowing them or aspirating the darn things? And so, have they been made sometimes in the past? Yeah, they were. This is sort of, you know what the thing looks like. And I would not recommend making these because I'm too worried about the thing coming out and the patient either swallowing or aspirating it. So now that we've talked about the types of partial dentures, what are the different parts of a partial? Okay, you've basically got your major connector, your minor connector, a direct retainer, a base, replaced teeth, and indirect retainers for class 1 and 2 partials. So what do we look at for the different kinds of connectors? Again, this is all written down in your notes. So your major connector is basically just the big main connecting piece that ties all the different parts of the partial denture together. So if we look at mandibular major connectors, typically we think of either the lingual bar or the lingual plate. So this major connector is the thing that goes around and hooks all the other parts of the partial together. And one of the classic questions that is typically asked on exams, because it's also relevant, is how much room do you need between the lowest point of the free gingival margin and the floor of the mouth, okay, if you're considering using a lingual bar as the lower major connector. And again, you need 7 millimeters at least because you want your width of your lingual bar to be at least 4 millimeters tall. And the lingual bar, if you look at those things, is typically half pear shaped. So if you look at the cross section of this thing, it's typically, with the teeth sort of being up here, gums, so that the narrow part of the lingual bar is at the superior edge. It gets fatter as it goes down so that you want a reasonable amount of cross-sectional thickness here, but it wants to taper toward the superior edge so it's not so noticeable to the tongue. And if these things could be a little wider than 4 millimeters this way, 4 millimeters is our minimum width we want to have. If it's a little more, that's great, but we want the superior edge of the lingual bar to clear or be away from the lowest point of the free gingival margin by 3 or more millimeters. And the reason for that is many times if you think of eating a vanilla wafer, not that any of you eat vanilla wafers that much, or Oreo cookies, soda crackers, let's pick anything like that. You chew them all up and you swallow, and there's a little bit of this pasty residue that's left in your mouth, this really finely ground up particulate food material. And can you see that stuff can lay? Woohoo. Let's go back to where we were, Jeffrey. That pasty, gooey material can lay right across the superior edge of this lingual bar sometimes. So if that's right in close approximation to the free gingival margin, it becomes an issue for caries and periodontal disease. Now, as with any partial denture, I harp and harp and harp at people that they really got to get these things out of their mouth and clean both the partial and their teeth very thoroughly a couple or 3 times a day. They can't just leave these things in all the time and they're going to be okay. So sometimes when people will talk about different partial denture designs, I don't want it to give anybody the illusion that a well-designed partial denture requires little to no oral hygiene. Because they'll say, gee, if we do this, then that's a self-cleansing area. Well, to a point. People still got to get these things out and clean them. So if you've got less than 7 millimeters from the lowest point of the free gingival margin to the floor of the mouth, anybody have any idea how you determine where the floor of the mouth is for a patient? You take an alginate impression. If you take a really nice alginate and mix it up nice and stiff, and that's how I want people to mix it up, you're going to get some pushing down or some distension of the tissues in the floor of the mouth. So you will appear to have more room than you do on your model, because the alginate will have pushed the tissues in the floor of the mouth down out of the way. So how do you figure out where the floor of the mouth is? Any thoughts? Perioprobe mouth mirror. You have the patient curl their tongue up. When they're curling their tongue up, you put the mouth mirror in there and take a perioprobe and measure from the lowest point of their free gingival margin to wherever the floor of their mouth curls up to when they've raised their tongue. And you could just measure behind different teeth. So when you get a cast, for example, of this individual, then you'd have possibly some measurements for 22, 23, 24, 25, 26, 27. And next to each one of those numbers, those tooth numbers, you'd have a number that would read anywhere from 3 to 8 to 12 to whatever. So you could just measure the distance from the inferior portion of the free gingival margin to the floor of the mouth. How do you figure that out? Have the patient curl their tongue out and measure it. So if the floor of their mouth comes up a fair amount and you make this lingual bar too low in the mouth, what do you suppose is going to be the consequence of that after you deliver the partial? It's going to get sore, and it's going to get sore as hell. So now when you go to adjust this, do you suppose this is as easy to adjust as the flange of a denture is? No, it's real hard. Point two, if you grind on that very much and thin this out, now we're getting the deeper kimchi all the time, because what's going to happen if you start thinning this thing out from the bottom edge? It's going to get weak and it's going to flex. Okay? So that distance, whether you're going to use a lingual bar or a lingual plate for your major connector on a lower partial, is dependent on how much room you've got from the most inferior portion of the free gingiva to the floor of the mouth. If it's less than 7 millimeters, you go with the lingual plate, which typically crawls up the lingual surface of the teeth about 60%, 60 to 75%. So 2/3 to 3/4 from the gums up toward the incisal edge. And then it just goes beyond the gums by about 2 to 3 millimeters. So this tries to shield that area. Can Gradu and Schnook get up under there? Of course. And so patients have to get these things out and keep them clean. Palatal major connectors, you can have somewhat of a full palate coverage, or you can have some areas in which the anterior and the posterior border don't go the full width of the palate. Those are all workable. Sometimes you can have an anterior and a posterior palatal strap. Again, these typically want to be 4 or more millimeters wide, otherwise they don't give much rigidity. For class 3 type partials, it's not uncommon to have sort of a mid-palatal portion. And what we're trying to do is, if we can, keep it away from the rugal area so it doesn't affect with speech. I speak with my lips and the tip of my tongue, the tip of my tongue, the tip of my tongue, so the sounds get confused a little bit if we have to take our framework up in this area. Sometimes there's no choice, but we've got to. But if we can stay out of that area, we will. If we got to go way back toward the posterior part of the mouth with an aspect of our framework, sometimes that can cause irritation of the soft palate. When they talk about different connector designs, in the old days they used to say, gee, we don't really recommend these because they're not rigid enough. Well, the design right here, many times if you have to make somewhat of a horseshoe-shaped palatal major connector, and especially if this area of the patient's mouth has a little bit of a deeper palatal vault, so that the curvature of here, or the shape of the major connector in this area, winds up being a compound curve. It curves not only this way, going around the arch, but it curves this way, because their arch is deep. So if you curve this way and this way both, you get a compound curve on the anterior part of this, and it may get fairly rigid for you. So don't discount these out of hand. But sometimes these others, pretty thin palatal strap, pretty thin palatal straps. Many times if you're going to make it this thin AP, they're going to compensate by making it thicker. And if they make it thicker, it becomes very evident to your patient's tongues, and they don't like that so much. So when there's a choice, you tend to basically cover a little bit more palate, but keep the framework as thin as you can. So it has minimal thickness. Very occasionally and not often, you may use a labial bar. The only time labial bars are typically used is if we really need to do a partial denture. And this one isn't the best example that they made this, but we have some few in which a person has a class 3 jaw tendency and their lower teeth all seem to just lean lingually. You'll see some of these people that seem to have a big pronounced lower jaw. You look at their lower teeth and all their lower teeth that they've got remaining all just really lean in. You put that thing on a surveyor and you try to find an orientation at which you can let a partial drop in and clear the lingual aspect of the lower teeth because they're all leaning in. It's really hard to do. So in some of those cases, I want to expose you to this. You won't run into very many of these. They're pretty uncommon, but they do exist. So again, these definitions are saying, okay, what's a major connector got to do? And then we've got a minor connector right here. So what your minor connector do is it hooks an occlusal rest to the major connector or other components. Here are two minor connectors in a case where they've got occlusal rest. Sometimes in the Kroll manual, they draw lots of partials like this. Sometimes in these situations myself, and this is personal preference, I will go ahead and run a lingual plate across some of these areas. Because I find many patients, when they've got these minor connectors going up, it feels fairly busy to their tongue. And their tongue kind of runs across there. There's just lots of stuff. The other thing is the ground up Oreos do a real nice job of laying in here. And they lay in here really good, and the ground up vanilla wafers. And so sometimes if I just cover that whole area with a lingual plate, so the lingual plate seals very nicely against the teeth up high, it may not go quite as deep into the vestibule, but it just shields that whole area. So there's a minor connector for some of those cases. Direct retainers. For a partial denture, the direct retainer is one of the main things that holds the partial in place. What's it consist of? It automatically consists of an occlusal rest, a reciprocal arm, and a retentive arm. So if we look at an occlusal rest on a tooth, when we're talking about these all the time, when you prepare an occlusal rest on a tooth, you want to carefully assess what is the opposing occlusion like. Have the patient bite together, assuming there are opposing teeth. How tight does the opposing cusp fit into the marginal ridge where you're planning on placing your occlusal rest? So sometimes students will just have the lower cast typically, or an upper cast, not articulated, and they don't have an opposing model. So when you're trying to make some determinations of occlusal rest preparation or how deep you might need to make these, a big consideration is how tightly does the opposing cusp fit up into that marginal ridge. There may be some instances, and when you articulate the models, the opposing cusp don't fit all that tight against this. So if you get a little bit of a positive rest, that's fine, but in those cases, you don't have to lower the marginal ridge all that much. People follow what I'm saying there? If an opposing cusp fits in really tight, you want your occlusal rest to have a positive seat. But if it fits really tight, anybody have an idea? Across this marginal ridge right here, where the partial denture framework is going to come and that occlusal rest is going to be, how thick would we like the chrome to be where it crosses over that marginal ridge? Any ideas? Okay, 1.5 millimeters. So a lot of times if the opposing occlusion fits in there really, really tight, and what happens not uncommonly is people get their partial denture framework back and they go to seat their framework and adjust the occlusion. And when they put the partial denture in, a couple of things you want to do when you're seating any dental work, from a single crown to whatever. If you're doing an amalgam, have the patient bite together and look at some teeth that we're going to call reference teeth. If you're going to do an amalgam that's broken down or a composite or a single crown, patient bites together without your restoration in place, and you see how the teeth fit. Then you put your restoration in, let's say a partial denture framework in this case. Look back at those reference teeth. Do they meet the same way, or are they apart? Well, if they don't come together like they did before, the only thing that changed in the whole equation is the new whatever you put in. Amalgam, composite, single crown, whatever. So not uncommonly, we put a partial denture framework in. The teeth don't fit the same. You start marking the occlusion. Where does it get high? It gets high right over the marginal ridge. So then you get out your marking paper and you start wailing on the partial denture framework with a high-speed diamond. Cool. But at some point, we're going to start to make that occlusal rest area pretty thin where it crosses the marginal ridge. So if we get it a certain amount thin and then you get your partial delivered just after you graduate, this usually happens when you're about maybe April of your senior year, and so you deliver the partial and you say, yes, it was sweet. You should have said it was fabulous. So then the D3 behind you inherits the case. Like you may be inheriting some of the cases from the D4s. And about 4 months after the D4's out the door, then the occlusal rest breaks off. And that was all poor planning. Let's say for the sake of argument, the tooth that you're going to go ahead and put the occlusal rest on happens to have a crown on it, an all gold crown. That's not uncommon at all. And the opposing cusp fits down into that marginal ridge really, really hard, really tight. What's one of the things you tell your patient before you start preparing the occlusal rest? Mr. Smith, we may make a hole in your crown preparing the occlusal rest. Now, if we do, we're going to go ahead and make the hole a little bigger, put a filling in it, basically prep it out for a class 1, put a class 1 amalgam in it, and then carve it out so we've got a nice positive occlusal rest. But the point is, if you're going to put an occlusal rest in that area and the opposing occlusion fits really tight, you've either got to steal a little bit off the opposing cusp and take a little bit more out of your crown area to make an adequate occlusal rest. Because if you don't, you're going to have problems with your partial denture framework. If you talk about the possibility of perforating a patient's crown before you ever lay a burr to the tooth, and then you happen to perforate it, this just happened last week in clinic with us. The patient isn't particularly upset. You talked about that might happen, and it does, and they're probably thinking, boy, they're really smart. They said that might happen. Now, let's say you don't say a word about it. You say nothing, and exactly the same thing happens. And you say, gee, Mr. Smith, we really had to make this rest a little bit deeper, and in doing so we made a hole in your crown, Mr. Smith, but we can take care of that. We can put a permanent filling in. Because you never, ever talked about it before, never came up. Now that it's happened, what do you suppose Mr. Smith thinks? You're really smart, or you screwed up, and now you're trying to cover yourself? Okay, now you're human beings. You'd feel the same way. And so on some of this stuff, the reason we want to know what the opposing occlusion is wherever we're planning to put an occlusal rest has real consequences. Because when you go to seat the partial denture framework, if the opposing occlusion is really tight and you didn't make enough room, you're going to have to start grinding on something at that point. So when we look at posterior occlusal rests, you can see one on a bicuspid here that's a DO occlusal rest. Sometimes in the class 3 type places for mesially tipped molars, or if we do crowns, we may do more of an oblong rest. Okay. If we're going to do anterior teeth for occlusal rest, typically cuspids, this happens to a lot. What we want to make sure we do is to have a positive rest. So if we look at the lingual surface of a cuspid, very often if we're going to have a lingual plate, the lingual plate may end up here, but we don't want our ledge or our rest to be up here. The rest needs to be in the thickest portion of the cingulum. And it can either be a little ledge across there, or it can be a little ball-shaped rest, but it must be a positive seat. I don't want the framework to just lean against an inclined surface. So here are some examples. Here's on basically a lower first bicuspid where we got a little bit of a divot in the mesial of that. You can see some of these areas here. And you can see on these maxillary cuspids where we made like little ledges or little divots in the teeth. We look at some lower arches. Here again, we've got little rests down here. We've built raised cingula. Here we built up some composite to put raised cingula on lowers. Now, in Europe, it's not uncommon that they'll put these incisal notches for incisal hooks on the partial. For the most part in this country, people find those unacceptably unaesthetic. So incisal hooks or incisal edge rests for lower anterior teeth somewhat used in Europe, not commonly used here in the States. We would usually go down lower on the cuspids and either use composite to build a raised cingulum or develop a ledge or a round-shaped rest in the thickest portion of the cingulum of the lower anterior teeth. You can read that definition as easy as anybody can. A reciprocal arm as part of your primary retentive unit, you're going to have an occlusal rest, you're going to have a clasp arm over here at the buccal, and then a thicker lingual reciprocal arm. Here's one on a bicuspid. Now a lingual plate, if it crosses the lingual of the tooth, can also act as a reciprocal arm. So all reciprocation, if you're going to have some part of the partial denture framework on the lingual of a tooth, that's going to counteract the fact that the clasp pushes on the tooth during seating and removal. It doesn't always have to have this shape. If one had a lingual plate that went across here, the lingual plate would contact the lingual of the tooth and serve the same purpose that this lingual arm does in these cases. The RPI system accomplishes the same thing, but with the RPI system, what happens is, if this is a mesial occlusal rest and a distal proximal plate, and there's an I-bar out here at the buccal pushing lingually, what happens is as the I-bar pushes lingually, this minor connector that goes up to the mesial occlusal rest touches the lingual surface of the tooth right here at the mesiolingual corner. Can people envision in their mind that if you try to push this tooth straight lingually, it can't move straight lingually, it bumps into this corner, and it would essentially have to rotate or roll? People follow that okay? That tooth could not come straight lingually. It would start to come lingually, then it would bang into this little corner, and when it did that, it would start to pivot or rotate distally. But once it started to try to rotate distally, it couldn't, because this distal proximal plate was here. So the distal proximal plate, in conjunction with this minor connector crossing this area of the tooth, the two of these working together have the same net effect as if we had a lingual reciprocal arm coming across here. So in this situation, if the labial clasp would try to push this tooth straight lingually, it couldn't come straight to the lingual. As it starts to come straight lingually, it bangs into this corner, and microscopically the tooth would try to rotate or roll around the distal of that. But as long as the distal proximal plate is in contact with the tooth, it can't roll distally. So these two working together essentially trap the tooth. The reason for this sort of a reciprocation arrangement was meant to make this area more wide open, and the authors that developed it felt that this area was more cleansable and got more stimulation. They thought it was healthier for the tissue in those situations. So when we look at retentive arms or clasp arms, we've got your standard cast clasps, and you're many times often using cast clasps. Of the infrabulge clasp, we usually will have I-bars or T-bars, and then something we used to use a lot here was called a wrought wire clasp, and we don't use those so commonly anymore. At the time the wrought wire clasp was very popular, the reason it was used was that the wire this was made out of is inherently more flexible. It has a higher modulus of elasticity. That is, it can be deformed to a greater extent and still spring back to its original position. So wrought wire has a different modulus of elasticity than a cast clasp. The reason for that is the way they make wrought wire, the way this is manufactured, is you start with a cast ingot of metal, of whatever the metal is. And then you start putting it through machines which start squeezing it through dies. So it comes in big and it goes out slightly littler. And then it goes to another die that's slightly littler yet. So they keep stretching this wire longitudinally, stretching it out, making it smaller and smaller until it gets to the desired diameter that they want. Now this whole process of stretching or drawing the wire has taken the molecular structure of the wire, because when these types of metals are cast, when they're just cast, the molecular structure is somewhat amorphous. It's all over the place. If they draw this thing longitudinally through many dies, what happens is the molecular structure of the wire gets more longitudinal. So the longitudinal nature of drawn wire makes the wire somewhat more flexible than the amorphous crystalline structure of cast metal. So the idea was, if we go ahead and take this drawn wire and we incorporate that into the partial denture, it'll take some of the stress off the teeth. So we won't stress the teeth so much. It'll be nice and flexible. The upshot was, as many times this stuff was too flexible because the wrought wire, when you come back and have a patient come back for post-insertion adjustments, the wire is sprung or bent out away from the tooth. So you get your 3-prong pliers and you bend it back in. And they come back a few weeks later and it's bent out again. And you get your 3-prong pliers and you bend it. You know where this is going and you bend it back in again. Now about the 6th or 9th time that happens, what do you suppose happens to your clasp? It breaks off. And so then you wind up doing some sort of a repair. The other thing that happens is anytime a lab, the few labs that still use wrought wire, for them to incorporate this type of a clasp instead of this type of a clasp, they will charge you about $50 more per clasp for doing this. How come? What they used to do in the old days is they would just take a piece of that wire and they would embed the wire right into the wax up of the partial. And when they cast the chrome cobalt, they would just cast the chrome cobalt onto the tail of that wire, thereby capturing it. But what do you suppose happened? You remember we talked about when you make drawn wire, you pull it through dies and the crystalline structure becomes linear? What do you suppose happens to the linear structure of that wire if they, darn it, Jeffrey, you keep doing that. If they cast hot chrome cobalt to it right in that area, they get a recrystallization phenomenon, where they almost but don't quite melt the wire. They heat it up enough so that the crystalline structure goes back to amorphous in that one area, the most critical area you could have it, right where it exits the framework. And so now after a few adjustments, what happens is the clasp breaks off right there. So what they should be doing, and this one demonstrates, is bending this wire in such a way that they bend the clasp, and then it comes down the framework and back here onto the meshwork. And what they do is they laser weld it back here, and they do get some recrystallization of the wire here. But in this area, it's all going to be encased in pink plastic. So the area where the recrystallization took place is protected from stress by the plastic that's processed here, so that here where it exits the plastic and the metal, it works fine. But it still, to me, is an inferior material because it doesn't stay in retention very well. And there's other ways you can design your partial to take the stress off the teeth. So is wrought wire used to be done? Yeah, there are some few faculty that still like it. I can't defend it anymore myself because there's lots of other ways to design partials to take the stress off teeth. So it's more expensive. It doesn't stay in retention as well, in my own opinion. And so I just as soon go with some sort of a cast clasp, either suprabulge or infrabulge. The denture base, basically what do? We've got this mesh portion in the wax up that's going to get cast in either mesh or lattice. That's where we're going to process the pink plastic. So the pink plastic gets processed and then our meshwork is embedded in the pink plastic because the tissue surface of the base in that area is plastic. We typically do this on class 1 and class 2 lower removable partial dentures. The reason we do it on class 1 and class 2 lower removable partial dentures is we anticipate the gums back there are going to change over time. They're going to resorb. And so if I've got a plastic base in that area, I can take a reline impression and I can reline it. Easy to reline. If I have a metal base, not so easy to reline. If I think an area is not likely to be resorbed because it's bounded by teeth, I may just make a cast metal base with bead retention. When will I do that? When the edentulous space is bounded by teeth on both sides. And I don't think it's highly likely to resorb. If I have a maxillary case as well and the teeth have been out for a period of time, I don't expect the maxillary case to resorb much. So I don't mind using a metal base with bead retention on the upper. We're going to have internal and external finish lines on these bases, so all that is it's a crisp area created in the chrome cobalt casting so that when the plastic is processed on here, the plastic has a clean place to finish. So you're going to have a thickness of plastic that's going to come to here. Then where the plastic stops and the metal begins, you have a nice clean break between the plastic and the metal. So these finish lines, whether they're internal finish lines, which is what's shown here with the processed plastic, or external finish lines on the oral side, that's a little step that's created in the casting so one has a clean, smooth transition from metal to plastic. It's a sudden little step right here, so you have a clean junction or a clean break for those. And that's just some more examples of finish lines that are on the outside of the denture base for clean finish lines. Replace teeth. Pretty simple. We just tend to use plastic replace teeth on these. There are some situations historically in which if you've got real tight space anteriorly, you need to mount these cases up, but what they may do is do a wax up and cast the lingual of those teeth in chrome cobalt, and then the teeth will be ridge lapped with no pink plastic base up here. So these are done sometimes. At other times they may have acrylic on the lingual side if room isn't such an issue. Indirect retainers and fulcrum lines. Basically, if you go ahead and look at page 96 of your text, it goes over these real thoroughly. I'm not going to bother to do that here. Your indirect retainers essentially are that portion that are going to resist occlusal movement of the denture, but more important, they're for orienting the denture framework or the partial denture framework for reline procedures. So indirect retainers are particularly helpful if you're going to reline a partial denture. So you've got your primary fulcrum line and an indirect retainer. Primary fulcrum line, indirect retainer. Primary fulcrum line, indirect retainer. And here's another one that just basically shows a class 2 primary fulcrum line, indirect retainer. So if you ever needed to reline one of these, you can re-index the framework in exactly the same way. So we've gone over a lot of that fairly quickly, but again, you had this material all last year. I'd say review it. If any of it's confusing, please don't hesitate to stop me in clinic.
You've been listening to a presentation from the University of Michigan School of Dentistry, which is dedicated to supporting open learning and open educational resources. This recording is licensed under the Creative Commons. It may be reused and redistributed for nonprofit use. Please attribute materials to the University of Michigan School of Dentistry and redistribute under this same license. For more information on how this and other University of Michigan School of Dentistry recordings may be used, visit www.dent.umich.edu/license.